Thank you for taking time out of your busy Tuesday to join us for another in our data webinar series. So today we're going to talk about how we can use data to enhance the supervision of care managers. Joining me today, we have Derek DeLange and Travis Atkinson with TVD Solutions. So thank you for coming today, gentlemen. Look forward to your input throughout the webinar. So, as many of you are probably very familiar with the transition from case management to care management, most CMHs have been going through this transition over the last few years. As behavioral health providers, we have more responsibility than ever before to monitor the overall health and wellness of those we serve. So over the past few years, many CMHs have navigated this transition. You may have changed job descriptions, changed job titles, provided trainings, maybe even set some goals for your agency or for your team regarding health and wellness. So you might think you're done, right? I think there's an important skill set that we may have overlooked as a system. How do we modify our supervision of care managers? I know that my supervision of CMH clinicians often focus primarily on documentation, timeliness, and completeness. You know, we focus so much on, are your assessments done? Do you have your treatment plans updated? Are your annual reviews due? How many periodic reviews do you have this month? So that can take up a tremendous amount of time. Case consultation was also a major focus, just digging into those cases at a clinical level. Productivity often becomes an area that is highly scrutinized. And all of those things are important, especially talking with our employees about their job satisfaction or their current engagement with their position, successes, and taking time to celebrate those successes. Those things are all really important. But I'm going to propose today that it is important for you as a clinical supervisor to develop some data-driven care management supervision skills. Data-driven care management supervision should focus on, in addition to those other basic supervision items, looking at utilization, maybe at the length of stay in a program, and what are the change in functional assessment scores or other clinical outcomes by the end of a certain length of stay in case management or POST or ACT. Perhaps it would be helpful for your team to be looking at how they're performing on the performance improvement project. My experience has been oftentimes clinicians at CMH don't even know what the PIP, maybe like the regional PIP, what it's even on. Sometimes supervisors forget what those performance improvement projects are supposed to be focusing on. So imagine the impact it can have if all of your care managers understand that your regional PIP is focusing on maybe diabetes and cardiovascular screening for people on psychotropic medication. And if they understand what you need them to do at the client level to improve your performance on that PIP. Another part of care management supervision is monitoring performance on integrated care measures. You may be very versed in integrated care measures, or you might not even know where to start with that. And today we're going to dive into those a little bit deeper in just a little while. We're also going to talk about data-driven assessment and coordination monitoring functions and how we can take those core case management functions and actually make them data-driven. So again, as I said, we're going to dive a little deeper into those various measures in a few minutes. This new set of supervision skills will require us to ask new questions. So for example, I won't read through all of them, but as a clinical supervisor, are you asking what percentage of this particular clinician's caseload has a primary doc and how that compares to the rest of your team? Or maybe you're wondering, would any of this clinician's cases be better served via an interdisciplinary team? Again, you might have an integrated interdisciplinary team for some of the folks you serve now, or maybe the only team-based care you provide is ACT. There's lots of options here as we move into integrated care. Maybe you'd like to know how frequently this care manager is coordinating with other healthcare providers involved in the case. So a lot of these questions you might talk about in supervision now, but I would doubt that you have data to support those discussions and that you're able to use data effectively now to monitor the performance in these various areas. A few years ago, I started to ask some of these questions for the team I was supervising. We had set some they were really great sounding health and wellness goals as an agency for the people we serve. But as a supervisor, I was struggling to figure out how to actually measure my team's performance in those areas. Unfortunately, the only way I could gather that data was to complete manual chart reviews. So it was very time consuming, and I was only able to look at a small sample for each clinician. I essentially kind of developed my own record review tool, dug into their charts, looked at maybe 10 different charts, and then shared my findings with the clinicians. And today, I'd like to walk you through a process for working with your ITIS department and the care managers you supervise to start answering some of these questions with data. And hopefully you'll find that this process will be more efficient and effective than just manually reviewing charts, which I know none of you probably have time to do. So let's take a look at one of those questions and walk through this process. So the question we're going to start with, Travis is our clinician today. So you'll hear Travis and Derek in a little bit. We're going to give you some samples of discussions that can occur at your organization. But first of all, we're going to look at what percentage of Travis's caseload has a primary doc, and how many of those consumers have actually seen their primary doc in the last year. So as care coordination supervisors, these are some of the things that we should kind of have our finger on the pulse of what's happening in our team. So that we identified a question. Step 2 will be to identify the data source. Now, I'm pretty sure that we would be able to find the answer to this question in a couple different places. Probably in our electronic health record, definitely in ICDP, the data analytics software, and probably even Care Connect 360. So the next step is, once we know where we can look for the data, we need to define how we're going to measure it. So how are we really going to figure out if there's a primary doc or not? Are we going to look in the contacts in the electronic health record? Do we know if clinicians even complete that section? Because maybe they're documenting it in a field in the assessment and they never use the contact section. If they're documenting in the assessment, is it a free text or narrative box where they might have the same doctor's name typed in, depending on the clinician, 3 or 4 different ways? So it might say Dr. Foster or Dr. Tony Foster or Foster MD. And from a data perspective, all of those give us a different, they're going to point us in a different direction. So it'd be important to know how that information is captured. If we're going to pull the data from ICDP, we need to know how does that tool define a primary care service, like which providers are included or what type of service is included. And Josh has gone over that in data labs of how to understand that report if you're going to pull it from that source. We need to figure out what date range we're going to look at. We want to have a discussion about how we want to slice the data. Supervisors usually have different ideas when they request data. Sometimes they want it by clinician. Sometimes they just want it for their team. How's IT or IS going to know what the team is? Is that defined by the supervisor? Is that defined by the cost center or service code used? These are all things that we're going to have to specify. Then, of course, we're going to look at the data. This is the exciting part, right? We're going to start by having a discussion with our IT department to make sure that we understand what data we're seeing. This is so important. You need to understand the limitations of the data. There's always going to be limitations with whatever data you pull out. There'll be maybe something missing or something that's not captured because of maybe it's SUD related, or maybe it is Medicare information that you can't pull in. So you need to have that discussion and understand what the limitations are, and don't use that as a reason just to get frustrated and not use the data, because then you're kind of guaranteed to always have cruddy data, right? If you never use it, it's not going to get better. But if you roll up your shirt sleeves, take a deep breath, and work on it with your team, you will get more valid and actionable data. Now, another thing I want to point out is if you get the report or query comes back from your IT department and it still requires manual work, talk to your IT department. Let them know what you need. I remember getting reports on various projects I was working on, and I'd take them home and I would actually get out an old-fashioned calculator and I would have my pad of paper and pen, and I'd be calculating averages and doing comparisons by cost center. Now, that was not an efficient use of my time by any means, and it leaves room for a bunch of error, right? Because I'm definitely not a mathematician by any means. So if what you get back from them the first time round is kind of only halfway to your answer, talk to them. They can probably very quickly change some code or add some things that will get it to you in the actionable format that you want. The less times you touch the data, the less room there is for error, meaning manipulating the data. Then you want to have a really critical discussion, which is with the care manager. You need to explain your need, to have them help you validate the data. Explain to the care manager that you know there's going to be issues with the data, but together you can find ways to strengthen the data. Ask the care manager to look over the data and tell you what looks correct or incorrect. Usually they can give you a pretty quick gut check. If you go to them, they'll be able to say, absolutely not, there's no way that's right, that's so far off. Or they'll be able to say, well, that sounds about right, let me look into it. Ask them to provide you specific examples. So, for example, with this scenario, I would take Travis the data, and maybe it shows that 25% of his consumers have a primary doc. And maybe he knows for sure that like 90% of his folks have a family doc. He can then look into it and find some specific examples of, case A, B, and C that show a primary doc in the assessment in this field. Then I can take that to IT and they can troubleshoot it. They can figure out if there was an issue with the code they used, maybe there was just a glitch in the electronic record, and then again we can improve the validity of the data by looking at those things in detail. You also want to ask your clinicians what type of benchmarking they would find helpful, because there's a little danger when you go into the benchmarking land where clinicians might feel like, oh, they just want to find out what I'm not doing well and how we don't measure up, and it could be perceived as negative. But if you ask the care managers, well, what would be meaningful to you? Do you want to see how your numbers compare to your teammates? Would you rather see how your numbers compare to a state average or a regional average? So find out what's meaningful to them, and then try your best, if possible, to benchmark it against what they identified. Then after you've had those discussions, you're going to go back and refine your query. There's always going to be little tweakings that you want to do to it. And then with the kind of new, refreshed, more valid data, you're going to take it to your clinician or to your team, and you're going to discuss how their performance compares to others. Now, please note the arrows going from step 3, 4, and 5 back to step 1. At any point, you might change. In fact, it's likely that you're going to change your question. Usually, as clinical supervisors, we know what we mean, and we'll think our question is really clear. But when then IT gives us what we asked for, we're like, no, that's not what I really wanted. And so your question may be revised multiple times, and that's okay. In fact, that's encouraged. So kind of a trick question here, but you see the question mark on your screen because there's actually a step missing. And if we had the ability to be interactive, I would love to hear what you all think the missing step is. But it's action. At CMH, we're usually really good about talking about data, right? We can sit in meetings and talk about the data for hours. Even though many of us specialize in facilitating behavior change with those we serve, we somehow have a disconnect and kind of forget that crucial step when addressing issues with our staff. So I encourage you to be really clear with your care managers. What do you want him to do? So I need to let Travis know, based on his data, what do I want him to do next week or within the next month? What do I expect his follow-up to be? because maybe my discussions will show that he actually, or I'll learn that his folks all do have a primary doc, so he doesn't need to do referrals. He's just not documenting it in the system. Or maybe I learn that he does need to follow up on referrals, and then I need to be really specific. How quickly does he need to do that? How much support, and this is what he'll know the answer to because he knows the people he serves best. Do they need assistance in scheduling that appointment, or can he just, ask them to do that and they'll follow up? And then, again, from a data perspective, how is this going to be monitored? Will Travis have the ability to run a report from his electronic health record showing him his performance? Will this show up on a dashboard for him? Or maybe as a supervisor, I'm going to have to go to Derek again in a month, ask him to run the report, and we'll look at his progress at that time. Okay, so these 7 steps probably sound pretty simple, but are actually fairly challenging to put into action. So let's look at another question. And this question is, how frequently is Travis coordinating with other healthcare providers on this case? So is information being requested, shared? Is there dialogue among the providers? And what we're going to do now is we're going to kind of zoom in, and we are going to listen to a first example of how this discussion might go. I will play the clinical supervisor, a role that I'm very familiar with, and Derek is going to play the role of the ITIS director, because we're from a small CMH and we don't have those fancy data analyst folks. So Derek gets to fill that role for us, a role that, again, he's very versed in. And then Travis is going to remember what it was like to be a clinician at a CMH, and Travis is going to act as our clinician. So bear with us here, and we're going to jump into the first role play. Action. Hey, Derek, do you have a few minutes?
Yeah, come on in.
Hey, I've got a data request for you. As soon as you can get it to me, because we've got those eval reports coming up, and my whole team has a goal on care coordination. So, like yesterday, I need a report on how often my clinicians are coordinating care. Can you get that to me?
Yeah, I should be able to do that. Fit that in my schedule here. Can you be a little more specific?
Well, yeah, I don't really know how you're going to find it. It's probably in the record somewhere. Like they're probably, I don't know, it should be included in their case notes. I mean, they better be frickin' documenting that. So if you can find a way to like look at the case notes and figure out if they have a primary doc or not, and then how often we're coordinating. Yeah, that would work.
Okay.
Okay. Pause. So now we're going to say that Derek pulled a report for me, and I'm going to take that rough data to my clinician Travis and kind of go over it with him. Okay? Action. Hey, Travis, do you have a minute? I have a report I need to go over with you.
What's it about?
Well, it's our new report on care coordination frequency, and I'm pretty concerned.
Why? What are you concerned about?
Well, you know how we have the team goal, I put it in your performance evaluation, that you should be coordinating care with healthcare specialists for the people you serve, and we ran a report, and the report shows you've only coordinated care in like 20% of your contacts. You have really medically fragile people on your caseload, so I'm really concerned that you're only at 20%.
That doesn't sound right. That's not my style. I mean, who even takes that data? That's probably not being accurate.
Well, it's from the electronic health record. Derek ran the report, so.
Well, have you tried to use that thing? It's impossible. So it's not even worth whatever we paid for it.
Cut. Sorry, I have to chuckle because I'm like having a trauma response to discussions with my clinicians in my IT department. For those of you that have, had to go to a new electronic health record in the last year or two, you know this pain, right? So. Clearly, that was the wrong way. Yeah.
I purposely played the role of a very bad data analyst there. I don't normally act that way as a data analyst.
Yeah, and you'll have a chance to redeem yourself, Derek. It's okay. We know that your skills are far superior to that.
All of our skills.
So, but again, in the crazy busyness of our life at CMH, that can happen, right? We realize, oh gosh, performance evaluations are due. I set this goal that sounded really great a year ago. I know that we need to be doing care coordination. Please, IT department, get me some data on that. And then clinicians, aren't you doing what I told you to do? So we can fall into that trap without even meaning to. But let's give this another try. And this time I have an assignment for you all. So as you're listening to this role play, please try to answer these questions. And so I want you to look at if you can figure out, what the question is we're asking, what's the data source we decide to focus on, how are we going to clearly agree on measurement, who looks at the data, what's his or her reaction, do we make any changes based on those discussions, how do we decide to benchmark, and just kind of pay attention to our overall communication. All right, action. Hey, Derek, do you have a second?
Yep, come on in.
Hey, I need your help. I've got this care coordination goal that we wrote for our team, and I wish I would have had this discussion with you back when I wrote the goal, but I didn't, so I'm hoping we can work through this together. I need to look at how often my clinicians are coordinating care with other healthcare providers. So if they have a primary doc or not, and then if care coordination is happening. And by care coordination, I mean, like, are we requesting information from the medical provider, or are we sending them information? Are we engaging in dialogue or having some type of coordination as a part of our visits? That kind of stuff. So where might we even look to figure that out?
Okay, is this something that we have like in the narrative of the note, or is there a field that we have to track this? Do we need to create a field to track this? I guess this is something we need to take some steps back to make sure that we've got the infrastructure in place to be able to do that.
Okay.
And then, go ahead, you had something.
Well, with what you just said, that I know that they track it in the narrative of their note, but based on that data request we went over last month, I know you told me that's not ideal. Like, to pull stuff out of the narrative is really ugly, kind of time-consuming and messy. But you know what? There's that button thingy on the progress note where it says, you know what? Let's pull it up. See here on the progress note where it says care coordination, healthcare coordination occurred as a part of this,
okay.
And they just click that.
Yep.
Well, maybe they're clicking it. I'll have to ask my clinicians. I don't know if they are or not. But you could pull that, right?
Yeah. Yeah, we'll have to find it in the database. So we'll work either with a vendor or look at the data dictionary to find it. But if it's on the front end and if it's measured there, we've got it somewhere on the back end that we can track in link
Okay.
those services.
So that I would like us to at least explore. And could we compare, like, let's say a clinician had 500 progress notes. Could you get me the number that had that box checked so I could kind of know a percentage by clinician? Like 60% of their notes included care coordination.
Yes, and are we looking at a certain subset of services here, or pretty much just any service?
No, right now, any service. Anybody on my team, anything they provide, whether it's ACT or case management or therapy, I don't care. So we'd have to, like, keep it real open.
Right.
Okay.
Yep.
Now the other part of it, so we could look into that. The other part of the question is if they have a doctor or not. So I'm trying to think where all we could pull that from. What do you think?
There's a few places.
Okay.
I mean, we track the PCP information on the assessment. We've got it in the consumer contacts, and then once again, there are some narrative fields that are available for that we'll really need to shy away from.
Okay.
Contacts is the preferred way to go because there we've got that link integrity.
Yeah, but contacts are a pain in the butt. You know, that takes a long time for the clinician. It's like a double step for the clinicians.
Right.
But we could look there. It just everybody might not be using it.
Right, and this might need a couple passes. You know, if we do get it out of out of the assessment or something where it is free-handed, we may run into a few cases where we've got the doctor's name spelled differently.
Okay.
So we'll be able to kind of look in this information, go through, find all the different spelling options that we run across, and we'll have to do some manual cleanup of that then to get it normalized where we
I mean, it doesn't have to be perfect. If you can give me something that's, close to capturing what's going on, I can make sure the clinicians understand we know it's not going to be perfect.
Right.
Pause. So now Derek and I continued to work on that. We finished our discussion. We got our initial data. And now I'm going to meet with Travis and go over that initial report with my care manager. Action. Hey, Travis, do you have time to go over a new report with me?
Yeah. What's it about?
I know you love these new reports. I'm always coming up with new data to annoy you guys with, right?
Yeah, this is great. You're doing a good job.
Well, I appreciate you giving me the time. So this report Derek pulled together on trying to figure out how often care coordination is occurring. Remember how each of you guys have a goal in your eval this year about increased care coordination contacts.
Yeah.
And I know based on our supervision, you've been doing some amazing work with your medically fragile people, but I just don't know if the data is going to reflect that yet. So could you take a peek at this list? It is showing that only 20% of your notes have care coordination as a part of it, and that just didn't seem right to me, but
yeah,
what do you think?
Yeah, that seems pretty low.
Okay.
I don't know. Let me look at this a second. Okay, so here's an issue.
Oh, good, because if you can point out anything that's an error on there, I can take it back to Derek, and then we can troubleshoot it. So what doesn't look right?
Yeah, well, this new individual has PCP.
Okay. Okay.
But I don't know. It's not. It's listed like they don't.
Okay. If you had time in the next week or two to look at that list and maybe just highlight the ones where, and then make a note of where the evidence is in the chart, because maybe the code that Derek wrote just didn't capture it, or maybe, as you know, with our record, maybe there was just a fluke that caused it to be missed. That would really help before I roll this out to the whole team, so I make sure I'm not wasting everybody's time with cruddy data, that at least it will be much closer to accurate.
Okay, I can do that.
Okay, thank you. Oh, one more question. As we use this to kind of look at our performance overall, what would be most helpful to you? Do you just want to see your own data? Do you want to see your numbers compared to like how the team is averaging with percentage of care coordination contacts, or would you want to see like I don't even know if a state average exists, but I could look for one. Like, what would be helpful for you to benchmark it against?
Yeah, I guess I want to know how well I'm doing with the rest of the team, but then I want to know how well our team does compared to whoever the best teams are in the state,
okay,
or in the country. Like, that'd be helpful to know, like,
okay,
who does this well.
So team comparison, but also if we can look at best practices like in the state or something. And,
yeah.
And again, I don't know if that data exists, but I can go look for it. Okay. Thanks. Cut. Okay, you guys. First of all, very good acting skills. Well done.
Thank you.
So let's debrief that a little bit. Derek, why was my request in the first role play not very helpful for you?
Well, mainly just it lacks specificity. And again, kind of back to what I was saying before, as an analyst, it's really my responsibility to ask the questions and to clarify any muddy water I run into. So, as we were trying to illustrate kind of a bad scenario all around, that's an area where the analyst would come back and really grill the requester with the questions, to figure out how to really maintain that integrity in the data set that they're going to be retrieving.
Okay, so the fact that the second one, I was a lot more specific. I mean, I might not have known the answers, but we had a lot more specific discussions of where we could look or what we would pull.
Exactly.
That's going to get us some more success. Okay.
And if I can just kind of jump into this too, one of the things, we're in kind of a scenario here where this is like an after-the-fact type deal where, we've had this goal in place, and maybe there wasn't the discussion surrounding the goal. And so this is a learning experience as we're creating these goals to really go through and identify the process by which we measure and then track the data, and then also provide a continuous feedback loop throughout the year, so it's not like, boom, all of a sudden we're at eval time and here's all the data. So this is something where we can use that as a learning experience. Outside of just the immediate task at hand, you kind of take a step back and look at better ways for the whole process. Yeah, when you're setting your SMART goals, they really do mean you should be able to measure it. So figure out how you're going to measure it when you set the goal, right? But again, CMH, as a CMH supervisor, you are so swamped and so busy and putting out fires. It happens sometimes. But you're right. We should have that discussion, when we set the goal instead of 9 or 12 months later. Right. So Travis, how did my statements make you feel in the first role play? Well, it felt like the data was becoming like a second supervisor to me. Like it was something else that was going to keep me accountable, but not necessarily in a pleasing way. Or at least that you got like this bionic arm
supervisor,
Yeah.
which you were going to start to shoot at me with.
So were you motivated to do anything differently in the first role play?
No, I was motivated to be defensive and to stand my ground and say why I'm an inadequate clinician and defend myself.
Absolutely. So what did I do that was hopefully more supportive in the second role play?
Well, the way you introduced the data, you were open to it not being completely accurate. You were saying this is how it's being taken right now, and you allowed me to have some input into the process.
Okay, nice. Any kind of closing comments that either of you have with those scenarios? Anything you would add?
Yeah, I think one thing that I would add to, again, kind of going back to the way that this is set up, is that you've got to consider all the stakeholders in the process and make sure that you've got, buy-in, ownership, make sure that, when we're talking about tracking PCP, you brought up the fact that in this scenario it was very difficult to get it into the context. Mm-hmm. Although contexts are our most reliable way, so it's okay, let's sit everyone down at the table and figure out how we're going to maintain data accuracy and reliability, but also not have the measuring of the data, the data entry aspect be more of a burden for clinicians and really maybe even get in the way of good care delivery, where they're having to track every single little aspect of something. It's in what ways can this be better automated and have it flow better with the whole care delivery process that, we don't see that sort of inhibiting factor in play.
Yeah, absolutely. And it's funny that you bring that up. In a few slides from now, we're going to talk about exactly that point of meeting the whole team to discuss and then create an effective and efficient process. So thank you. Now, as I mentioned earlier, during the transition to care managers, most CMHs provided training for the clinicians on how to effectively coordinate care, learning about chronic conditions and all that important stuff. But I wonder if CMH supervisors feel that they've had an exposure or training to have a thorough understanding of what your team needs to do to ensure that high quality services are being provided, and basically so you can demonstrate that your team is reaching the triple aim for those they serve. So I'd like to take a look at some resources that will help you to better understand how your team's performance will be measured in the upcoming years. So we're just going to take a minute and talk about this. As you see, the tools that actually have a link to the particular tool or website I've included here, so you can use these if you decide to dig in a little deeper on your own. But first, I'd like to start by talking about the CCBHC Readiness tool. Most of you probably know that the Excellence in Mental Health Act is making CCBHCs, or Certified Community Behavioral Health Centers, sorry, that's a mouthful, in making these a reality. And Michigan did put forth an application to request planning grant money. So if it is awarded and becomes one of the 8 states to start this journey, the state of Michigan will be looking for 8 to 10 sites to become a CCBHC. So if you look up this readiness tool that the National Council created, and again, please keep in mind, a readiness tool is just one tool in your tool belt. It's a starting point for your own kind of intensive work plan that's going to highlight your areas of strength at your organization, your areas for growth, but it can be a building block for you. So this readiness tool, I just picked a few of the standards from this tool to highlight here and connect them to some of those questions that care management supervisors need to be asking. So for example, there's a standard about interdisciplinary care. And we mentioned earlier, you might be thinking, gosh, would any of Travis's cases be better served via an interdisciplinary team? He's a great care manager, but holy cow, he has really complex, medically complex folks. Maybe it would be great for him to have a health-related peer and a nurse on his team. And I want to point you to a resource if you're not already aware of the 4-quadrant clinical integration model. This can be a really helpful way of kind of looking at your patients through a different lens and determining what their needs are. At a CMH I worked at previously, a process improvement team actually created a cheat sheet for clinicians, and we used this quadrant model and then identified on that cheat sheet the different care coordination tasks that you would perform depending on the quadrant. So for example, you know, a 25-year-old very healthy person with, you know, their first episode of depression is going to need a different level of care coordination than a 58-year-old schizophrenic with hypertension, asthma, diabetes, thyroid, and a seizure disorder, right? You're going to have to do really different care coordination for those two patients. So this is just one way of looking at the people you serve and trying to figure out what type of care coordination you should be offering. Again, there's many other standards like the 24-hour follow-up standard, and that's for following up within 24 hours of discharge, whether it's from a medical unit, a psychiatric unit, or even substance use. So that's a little bit beyond, you know, what CMHs currently are required with their follow-up within 7 days, I believe, from an inpatient unit. So it will be helpful as a supervisor to make yourself aware of these different standards and then figure out what's meaningful to you. For example, under the monitoring health indicators and risk, what's meaningful to your team? Some CMHs have done fabulous work with tobacco cessation, and they have developed internal champions, and they have just tackled this for everyone that they serve. It becomes a part of their overall care. But maybe for you guys, you want to focus on diabetic screening of, you know, folks on psychotropic meds. So start with one thing that is meaningful and then figure out how you're going to monitor that. Another area to look will be the NCQA measures. Again, some of you may be very well versed in this, but if not, check this website out. There's a lot of great resources at the NCQA website. And the CCBHC, sorry, that one just still does not come out smoothly. That readiness tool actually references 22 NCQA measures, and then there's an additional 10 total quality measures. For example, in the last webinar, Travis and I introduced you to a few of these measures as possible metrics that you might be wanting to be monitoring within your crisis residential services. So again, I only listed a few of them, but this is going to be a great place for you to look to determine maybe we want to be focusing on BMI, and so we should look at the measure 0421, preventative care and screening BMI, and how are we from a data perspective going to monitor that and measure our performance over time. Maybe those steps feel a little too big for you. Maybe those feel like you just went to your first Zumba class and you're going to fall on your face because you just cannot follow all of those steps and all of those standards and measurements is too overwhelming. So just take a peek at the CARF Health Home Standards. Now, this is not the full list of standards. This is just kind of the general overarching things that CARF is looking for. But with where our care is headed and how our value-based care, the direction that we're headed as a system, you should be looking at these types of accreditations and these types of standards. So as you see here, there's a lot of similarity, but it's just a bit more general. So maybe at the local level, you guys could decide what critical health indicators you want to monitor or how you want to support your folks in the self-management of their chronic health conditions, or what prevention and education services you want to be providing. So I would encourage you to find your local CARF manual and check out those health home standards. So perhaps you're, as I said, already really well versed in these standards, and if so, you're ahead of the curve with preparing your team to be successful in the upcoming years. But if not, I really encourage you to use these links to review these documents and standards, find something that's meaningful to your team, and start to use that data to monitor your team's performance. And one last way of infusing data into your supervision is by focusing on the assessment and coordination or monitoring functions. Now, this is by no means a comprehensive list of the data elements you could use, but I just wanted to give you a few examples of how you could use the data that we now actually have available to us and a responsibility to use to improve our care to enhance how we perform these targeted case management functions. Many CMHs currently, their practice is just to ask consumers who your family doc is, what medications you're prescribed, when you last saw your doctor. But this can be really challenging, right? Because many of those that we serve are poor historians. So I encourage you to consider how you could start using tools such as CareConnect 360 or ICDP, or a custom query that your excellent IT department builds out of your electronic health record to use this data to inform your assessment. We can also use data to strengthen our coordination and monitoring. Rather than just relying on the consumer's verbal report, did you go get those meds at the pharmacy? Yep, sure did. Yep, check that off. They got their meds. We can actually see in the claims data, if they filled that script. Or we can see they told us that they had a family doc and a gynecologist and that was it. But when we look, they've actually seen a neurologist. They've seen 3 other specialists for other health conditions that you didn't even know existed for them. Another really important point is as Medicaid HMOs increase the care management services that they're providing, it's critical that we know if they have a care manager working with our consumer. Otherwise, we might be duplicating efforts, or gosh forbid, we might be sending mixed messages to the people we serve. So remember, there are challenges with this. Depending on what tool you're using, there's going to be a claims lag. So again, be sure to know the limitations of the data you're looking at. It might not include substance abuse. It might not include Medicare data. It might be too old for the purpose to answer the question that you're focusing on. And you might only be able to answer it, for example, like completed lab work. So ICDP is going to show if a lab service was offered, but it's not going to give you the results. So you might need to be a part of a health information exchange to get those results, or just use good old-fashioned local methods for exchanging healthcare information to get those results. So there's a lot of questions to really be answered to try to use that data to inform our assessment and coordination or monitoring functions. It's not as simple as just telling the care manager to start collecting this data. Most care managers have little to no experience in the ICDP system, probably don't even have access to it. Same with CareConnect 360. Even if they did, can you imagine the extra time it would take them to look this information up? I know my clinicians would not have been pleased if I had said, hey, in addition to those tons of forms I already have you complete with people at intake, I now need you to go into this program and look up who their doctor is, the last time they saw them, verify all the meds they're on. I think I might have a revolt on my hands if I did that. So this is a great opportunity for you to nominate a process improvement team. It will take all the players, and this is what Derek so eloquently mentioned earlier. You need to have all of these folks at the table, your QI staff, your IT or IS department, medical records, the clinician, a med clinic nurse, and a consumer or peer, to be able to figure out at your location, how are you actually going to infuse this data into your targeted case management functions. And I want to remind you, you'll see that the consumer or peer one is highlighted there. No, my son didn't just get a hold of this and make a mistake there. I did do that on purpose because it's so important that if you haven't started to have discussions with those that you serve about the data that you now have access to and how you're going to use it, you really need to start having those discussions. It's critical to help consumers understand that our goal is to empower them to be more activated and informed patients and not to spy on them or to control them. So we need to have them be a part of these discussions and have them help us create these processes.
Sarah, I think that's a great point because you can help to bring some context to why we ask so many questions and why we ask for releases of information. When you can show that we're really trying to help people with what they're doing, it might change their approach and from being skeptical of the services that are being provided to recognizing that the more data that we can gather, the more helpful we can be.
Absolutely, and that we can use that data to improve our care, not just for them, but for everybody in the community. Yeah, for sure. So remember, It's a marathon, not a sprint. I don't want to see your IT, QI, and clinical supervisors. I don't want to see you guys all passed out, giving up, feeling overwhelmed and dehydrated. It's not what we want. These process changes are going to take time, probably many months, if not more than a year. So pace yourself. Rely on quality improvement tools to help you transform your team, and remember how critical communication is to get the buy-in and understanding from all of those folks involved in these changes. And as I highlighted in step 7, action is critical. So as we conclude today, I'm asking you to identify a meaningful question regarding care management, and then follow up on the steps 1 through 7 that we outlined earlier. Now, we know that incorporating data into your supervision is definitely going to be a workout. And I don't know about you, but I love to have music keeping me kind of energized and in the groove during my workout. So Travis has been kind enough to write us a data song.
And as Sarah said, this song is called Data Song. Times are changing, yes indeed. Things ain't the way they used to be. Data come along and change the world, making analytical boys and girls. Data gonna help us, wait and see. Data been an old friend of IT. It can be a friend to you and me. You collect data, data no faking. Data gonna drive decision making. Know your data and use it, that's the key. If a care manager say no to data, say wait and see. This will help you do your job more efficiently. What if you could work smarter as a whole? Make all your productivity goals. It's just like Patrick Henry said. Give me data, give me death. Maybe that's not the way he said it, but I think you and I both get it. Use your data, use your head. Use your data, use your head.
Woo! And you can start your next staff meeting with a data song. Who cannot be excited about data when using the data song? Thank you all for taking time to join us today. Thank you, Derek and Travis, for your assistance. We will be speaking with you all again soon for the next webinar. Take care.